from both perspectives, a practitioner and an administrator, I learned the business aspects of medicine, which are going to be very clearly presented to you in this movie tonight. The hospital where I worked was a large public hospital in Miami, and Miami had, at the time, 500,000 people, 500,000 people who had no health insurance. And they had no other place to go than to come to the public hospital. So our physicians and our trainees were their physicians. The hospital itself had 1,200 beds. A third of them were occupied by patients who had no ability to pay anything. A third of them had Medicaid. And while Medicaid is an important contributor to health care today and absolutely should be approved by the state of North Carolina for the 500,000 people we needed in this state, it, at the time, and I think today, didn't pay the cost of the care that was required. The other third of the patients were private patients of the University of Miami faculty. And there was something then that exists today called cost sharing. The paying patients were asked to pay enough that they covered those who didn't have any insurance at all and the shortfall with Medicaid. So when someone says, we have a system today that provides care to everybody, all you need to do is go to the emergency room, don't accept that. It is the work, the care that's rendered is as good as it can be, but it is the most expensive. And if you wait until you have an emergency to go get care, that's not the best time to get care. It's not preventive care. And when I first started in the 1970s, the outcomes of health care in this country were the best in the world. They no longer are. You'll see that in this movie. We are a non-partisan group. We recognize that in Washington and in Raleigh, healthcare is a partisan issue. Don't understand why. We are convinced, and I hope you are or will be, that healthcare is a responsibility of the government, both state and federal government. We need to be providing it to everyone. And what you're going to see in this movie, which was produced by a small business CEO in Pennsylvania, is that his healthcare costs for that company were getting so high, he said, we cannot afford to continue to pay more and more and more. There's got to be a better way. The other thing that he understood, and you will understand if you don't already, is that there's a lot of waste in our system. We learned this morning that our healthcare expenses this year are going to reach $3.7 trillion. And 1/3 of that, fully 1/3 of that, is administrative overhead that adds nothing, nada, ninguna, to healthcare, to the quality outcomes that are important to us all. So thank you for coming. We hope at the end of this you'll be inspired, maybe to work with us. Our role is one of education, trying to have people understand that what we have today isn't what it could be, and there are alternatives out there that are not so complicated to introduce here. In 2018, employers paid an average of $19,000 per employee. As the Canadian businessman said, I don't understand why businesses although Fix-It doesn't address this, when everyone has access to health care, it's going to also improve the quality of care and the outcomes so that we will have a healthier population. Let me invite the panel to come forward for your questions. Althea Bowes, Denise Fink-Rothman, MD, Yele Aluko, Dr. Yele Aluko, Dr. Jessica Shore-Sachs, and Dr. Larry Jones. As they're coming up, although Sister Andrea has included a short biography of everyone, I want to point out that we are a subcommittee of Healthcare Justice, North Carolina, Charlotte, and Dr. Shore-Sachs chairs the Charlotte Division of Healthcare Justice, North Carolina. Okay, we are open to your for your questions. And Cindy will bring a microphone for you. Let me start. Let me get the ball rolling. If I could ask Jessica Sachs to address some of what we're hearing today. One of the issues is that everybody is very happy with their employer health care. Why are we trying to upset the apple cart?
So that's something that you'll hear, and if you've been watching the Democratic debates and so on, one thing that you hear is that most people in this country are happy with their employer-based health care. However, actually, most people in this country don't have employer-based health care. It's about 49%, and of those, about 70% are happy. But they're not as happy as people who are on Medicare and Medicaid. Like 3/4 of people who are on Medicare are happy. So they could be happier. Also, when polls ask who's in favor of Medicare for all, the majority of people will say they're in favor. And then what happens next depends on what the follow-up question is. But if the follow-up question is, would you be in favor of Medicare for all if you could keep your current doctors and hospitals, that goes up way over 50%. People are willing to have Medicare for all and give up private insurance as long as they can keep their doctors and hospitals. What people are really loyal to, generally, is their doctors, not their insurance company. And then the other question is that if you talk to people who have employer-based coverage and you say, would you be in favor of Medicare for all if you could keep your coverage, if you had just as much coverage as you have now, that number is also about 57%. So when you hear people say, we can't make a change like this because people won't give up their employer-based coverage, that's not really what's shown by the polls. What the polls show is that people are in favor of Medicare for all, and they're willing to give up employer-based coverage if they get a better deal with Medicare for all, which they would.
Thanks. Dr. Jones, do you have a comment on that?
Yes, briefly, in my role as a practicing physician, that was one of the issues that I constantly struggled with, is having patients having adequate coverage for their care. So we had to come up with pretty different kinds of ways to make sure that patients were able to get the services they needed. Frequently, making sure that they would have access to specialists through community health centers, and really became a piecemeal way to provide care for individuals, throughout. Medicare for All gives us an option to be able to have universal coverage similar to what we have and was described within Canada, as well as what is currently the system in England, which is a two-tiered system. So the opportunities to improve healthcare in access, in coverage, reduce prescription costs, I think is an opportunity we really cannot resist.
Dr. Luco?
Yes, I think that if one samples a population of people that already have healthcare insurance, in general, you're likely to have positive sentiments expressed about having healthcare insurance. But that question completely ignores the fact that there are many people that don't have healthcare insurance. And again, talking about employee health insurance, employment is sometimes transient. So you can go in and out of having health insurance. So I think that those people who are employed and say they're happy with their health insurance are justified in saying so, but they're looking at things from a very personalized and somewhat selfish perspective. Because if you look at the broader picture of the problem, the 20 million or so people who are uninsured today, despite Obamacare, the Affordable Care Act, are certainly not happy that they don't have any insurance. So the problem is larger. If you ask the question to people that have employee health insurance, if the question is, do you want to continue to subsidize at high rates those that don't have health insurance within a healthcare system that is inefficient and that does not provide transparency of performance and does not provide accountability of providers, hospitals, insurance companies? If you ask that question, almost everybody would probably say no. So I think the question is a broader question, and it's a much more complex one.
Can I just add one more thing too,
Sure.
which is, my suspicion too is that these large number of people who are satisfied with their health insurance are mainly people who are not sick. What I see people in the room nodding, I mean, most of us have probably had the experience of at least knowing somebody who actually got sick and then found out that their insurance didn't cover what they thought it was going to cover, and then were hit with big bills. Well, you know, what's insurance for? It's to protect you when you actually are sick. So I think that health insurance that makes well people happy really isn't doing its job.
Yes, Althea, if you would provide your perspective as someone who had employer-based health care and now is not.
Right, and felt like I was imprisoned for many, many years and had a dream and could not fulfill that dream because I was stuck. I felt like I was stuck. And there are so many people out there who, you know, who feel the same are not fulfilling their dreams or, you know, just feeling imprisoned. And it's just not a good feeling. You know, feeling that you're stuck and having to stick with that. And with the insurance, like you said, we're paying more every year and we're getting less. I had insurance, had a small accident at home, and I paid so much out of pocket. So, you know, there's still an issue with the insurance. And people who, like you said, it can suddenly change for whatever reason. You can be employed one day. I've talked to friends who are like, oh, it doesn't really affect me. You know, I have health insurance, and before you know it, whether it's a layoff or for whatever reason, you're just without insurance, and here you are. So.
Questions? Yes, ma'am.
What are the objections to?
Thanks.
What are the objections to the single-payer healthcare system? And who are the objectors?
Dr. Big Rothman, would you address that, please?
Currently, there's a group called the Partnership of America's Healthcare Future. Doesn't that sound good? That's a group of the insurance companies, the pharmaceutical companies, and the hospitals that have all come together with huge amounts of money and are financing all of the propaganda that you're seeing on television and that you're hearing on the radio about how Medicare for all is never going to work. There's going to be huge lines and we can't afford it. And it's their money that then is also financing much of the Congress through lobbying. And so we have a huge fight to try and get Medicare for all through because we're fighting all of that cash.
And there is just a barrage of misinformation, actually disinformation. The arithmetic is not complicated, and yet you hear over and over and over again, we cannot afford this. Boyce, did you ever?
I can make a brief additional comment to that. Just to give you an example, put it in pure numbers. For every congressperson, there are 3 lobbyists between drug companies, insurance companies, and hospitals. When you look at the 435 folks that sit in Washington that are making all of our laws and making those decisions for us, each one of them, there are 3 people numbered for each and every congressperson. That's the kind of pressure that the legislators are up against and that we will be up against in terms of making this change. But this is something that we all need to do for ourselves as well as for that next generation.
Thank you. Judge?
I think the first time I watched this, I had the same question. What happens to the insurance companies? They go out of business or they sell different insurance. And how logistically do we transfer from private payer to single payer? How's it going to happen?
Dr. Luco, do you want to handle that one? At least to begin with?
Yes. There's a reasonably easy way to get into Medicare, 765. It's not very complicated. So there's a business model that already exists that allows populations to get insured through Medicare. It's all about making the decision, purchasing the infrastructure, scaling it for larger populations to replicate the current Medicare business model. It is a fact that there are vested interests that are very powerful both by way of financial resources and political capital, such as insurance companies, commercial ones, that provide services for all of us that have commercial insurance, but are vested in preventing that transition to a more efficient model. Will they go away? If there is enough advocacy, enough demand, and political capital to move away from waste to efficiency. Indeed, the insurance companies themselves are in a position to become more efficient without any external pressures demanding it. But every single component within the value chain within healthcare, whether it's hospital systems, insurance companies, pharmaceutical companies, medical device companies, are thriving within an environment and an ecosystem of inefficiency and are making a lot of money. So if there was internal efficiency development, we wouldn't be where we are today. The current insurance companies have failed with this business model to reduce waste. The problem is waste. $1.2 to $3 trillion every year that is complete waste. And how can we justify this? So it's not so much that they're going to go out of business. Being in business is creating a problem. So if they want to retool their business models and their internal operations to become more efficient, eliminate the administrative redundancies that exist across all commercial insurance players in America, then something must be done. So yes, they might go out of business if they can't retool their business models.
All right.
Yes, Dr. Sachs?
So currently, the insurance companies are seeing the writing on the wall, and they are already moving into other fields of business. So I don't think you have to worry at all about the insurance companies. They have a lot of money, and they are very smart. So take that one off.
Dr. Sachs?
And I just want to add that there are about 2 million people who work in the insurance companies or work in hospitals and doctors' offices interacting with insurance companies. And that sounds like a lot of people, and nobody wants to see a lot of people unemployed. But a couple of things about that. That's also about the same number of people who get fired from jobs every month in the United States. It's a very small part of the overall workforce. But nobody wants to see people unemployed, and both of the bills in the House and the Senate have transition money for people for worker displacement that would either retrain people and help them transition to other jobs. Some of the people who work for those companies are people who are clinically trained, they're doctors and nurses, or the people who could be clinically trained. If we have a healthcare system that covers everybody, there'll be more need for people in those jobs actually delivering healthcare to people. So we could transition some of those people so that they were actually doing something positive for people.
Wait a second, Judge. Are we gonna have you ask that question again, the next session? Or have we made some
No,
progress?
you made progress this time, but I have another question if I can ask
Sure.
you. Because I've seen these commercials that you're talking about, and they're really confusing, because I've seen this film and I see this commercial, and, you talk about these small hospitals that are going out of business if we have Medicare for all. They talk about rural hospitals. Can someone address that issue?
Well, they're going out of business now.
Yeah.
I don't believe that I have heard that if we had Medicare for all, they would go out of business. Because a lot of those rural hospitals, and someone else who's more knowledgeable than I should address this, okay, Dr. Jones, they are in areas where individuals probably are eligible for Medicaid. And in North Carolina and a number of other southern states, we have not supplemented the Medicaid patients. But Dr. Jones, do you want to, so I don't believe that Medicare for all is going to drive hospitals out of business. Dr. Jones.
Clearly not. I mean, one of the boons for hospitals at this point was the ACA. The fact that more people are covered has been a major boon for hospitals because the number of patients that were coming in without insurance has dramatically decreased. As the numbers would fall from either limiting Obamacare or to just put further restrictions on it, hospitals actually lose in that situation. But let me take you back a little bit further. I was formerly the chief medical officer for a hospital in a system that was fairly rural. Most of their hospitals, except for their tertiary hospitals in rural areas. And their commitment, when they went to Washington to really see what there was that they could do to get additional funding for those hospitals. And this is back about 2010. There was really no commitment on the part of the U.S. government and CMS to really further assist those hospitals. So what you're seeing now is going to continue because of the drain on resources. The dollar can only go so far. This $1.2 trillion in waste is not something that can be made up very easily unless you change the system. Let me also go back to your other question previously about the transition period. According to the bill that's proposed in the House, there would be a 2-year transition period for patients to transition. Residents over 55 and those under 19 will be covered in their first year of Medicare. The second year, then all Americans will be covered. That is how the current bill would suggest the transition would take place, so that all Americans will be covered over a period of about 2 years.
Let me follow up on that, if I could. I think there's a group of folks out there saying, that's too fast. Why not transition over a longer period of time. Do you want to address that, Dr. Sachs?
Actually, transitioning over a longer period of time just makes the whole thing more complicated. Because, I mean, really, how are you gonna do that? You have two payment systems, you know, what's gonna happen in the interim? It actually would be more efficient to make a fast transition. When we implemented Medicare in 1966, we did it all at once. You know, we didn't say we're gonna do this gradually. And it would be more on that model. I think.
And there were no computers, and all of the seniors signed up in a year's time, the majority of the seniors.
And if I may add, back in 1965, 1966, when Medicare was legislated, there was a groundswell of resistance from the American Medical Association, hospital associations, in denial of the need for health coverage for seniors. So fundamentally, you're dealing with us as physicians that work within the healthcare space, patient advocates, hospital systems and leaders are fundamentally patient advocates, but are not vocal enough in the advocacy and the importance of healthcare coverage and access. It is nothing new. It happened back then. So what we're seeing today is just a different iteration of providers and others who are comfortable with the current status quo and are fearful of the future, but fundamentally abdicating a primary responsibility, which is to be a patient advocate first and foremost.
To build on that, yes, please. Go ahead. There are statistics which show mortality rates by age for about 20 countries. The United States is at the bottom until we get to age 65. What happens at age 65?
Medicare.
At that point, the curve goes way up, such that in the 80s and 90s, our mortality rates are among the best in the world. That is another endorsement of Medicare. Yes?
I was listening to C-SPAN the other day, and Dr. Lugar has hit this Medicare for all. Would that rein in the pharmaceutical companies? And you said we need to get out here and be advocates of this, but I was appalled. They had a program on healthcare and the pharmaceutical companies, and they named 3 major pharmaceutical companies, and you know they're generic drugs. And one major company has done something to block anybody from making a generic through 2024. And others have the expense for diabetes, the insulin is so expensive, it's in the palm of, I think, about 3 insurance companies. And yeah, and they even talked about some, I don't remember the medication, but to make that pill is about $1.50, and they charge $700 for it. So Medicare for all, can we as advocates do something, because these companies are killing us?
Dr. Finkel-Hoffman, do you want to address how would pharmaceuticals be managed under Medicare for all?
Pharmaceuticals would be covered under Medicare for all, and so prices would be fixed I mean, there would be no cost, it would not cost any of us any money. Medicine would be totally covered. So, that would be, the government would be negotiating with pharmaceutical companies and setting prices and just say, no, you cannot charge that amount of money. You cannot justify that charge.
And
Everyone in the world pays less than we do.
it was noted in Fix-It, the VA can compete for drug prices. For some reason, when Medicare D was passed, that was precluded. Medicare cannot compete for reduced prices under the current law. That doesn't make any sense whatsoever. So it's a good point, but there's certainly with a single point of control, this should be at least partially resolved, if not completely resolved. Yes?
The donut hole,
Right.
what happens to that if we do Medicare for all? Does it go away?
Yes.
Or is it still there?
All of that stuff, if we have Medicare for all, everything is paid for. Your hospitalization is paid for, your doctor's visit is paid for, your medicines are paid for, your eyeglasses are paid for, your hearing aids are paid for, and long-term care is paid for when you're 90 years old and you need to be in an assisted or a long-term living facility, that's paid for.
So
That would
various
all be
components,
included.
like Medicare D goes away. There's no need for it.
All of your medical devices would be paid for, and assistive equipment that you needed in your home for your care.
A couple of questions, and anybody can take the question. One, what are we looking for in the Democratic presidential candidates as they put out their different healthcare for all things? What are we hearing some of these differences are in the plan that's the current Senate and House bill? Which is obviously, I guess, sponsored by Bernie Sanders, but what are the other candidates that are like Joe Biden? What are some of the differences that they're talking about? What should we be listening out for? And then is the Medicare for all, is it critical that there's no option for private insurance? Is that because there are other countries like New Zealand and Australia where patients can still have private insurance and physicians can work in both systems? So is it critical that the Medicare for all movement not allow for people to opt out and have private insurance if they want to? And then the other question is, what happens to physician salaries? What's been looked at statistically? What happens to physician salaries, specialists, primary care doctors, when we transition to this healthcare for all?
So I heard 3 questions, and you all should decide who's going to take what. Which is the best proposal currently put forward by the cacophony of discussion occurring amongst the Democratic candidates, number 1. Number 2, number 3 is what's going to happen to physician income. Tell me what number 2 was.
3 was, can we still have a private insurance
Oh,
option?
private insurance.
If we want it.
Do you want to start, Dr. Jones?
Sure. Number one, with regards to, let's start with the second part. That's the easiest part. Because I've had the opportunity to visit and have a little experience in terms of trying to understand the English system. And done a little additional reading in terms of what it looks like now. England has a 2-tier system. They have one where you can have insurance and opt out of the governmental system. And then there's the governmental system, which I believe about 80% of folks in England are in the governmental system. You know, is that an option for us here? Personally, I think that is probably what we'll end up with, in my personal opinion, because of the power of the insurance industry. But I think the vast majority of people would go with the Medicare for all situation. That gives us the greatest opportunity for savings. And with the change in the whole demographics around employment, 20 years ago, folks could work at an institution for a lifetime. Now, people change jobs every 2 to 3 years, sometimes a little more frequent. The lack of stability, the lack of, let's say, connection between the employer and employee has completely disintegrated. So clearly we have to get rid of the employee-based insurance, and that's at least for the common man. So that's my view in terms of what I feel probably end up with.
So, and I feel very strongly that we have to go for what's best for this country and not go for any kind of a silly compromise with the health industry. There is an inefficiency to have two-tiered system, and any kind of complication and it adds to the inefficiency and adds to the cost. We need a one system that's uniform for everyone. That's the best. And we need to go for that. And currently, my understanding is the only two candidates for that are Elizabeth Warren and Bernie Sanders.
Dr. Luco?
So I will push back on that because there are models that work outside the United States that are universal single payers, and there are two-tier systems in Europe and elsewhere that actually work. So I think it can work if you have a dual system, if the rules of engagement are clear, understood, and executed upon. And by that I mean providing access to healthcare is one issue, and managing the expenditure is another issue. The expenditure management has a lot to do with the practice of medicine, the procedures that are done by physicians, the drugs that are ordered, the admission of patients to the hospital. So they have to work hand in hand, the healthcare financing and the healthcare behavior of providers, so that you do not have excessive expenditure. If you have a single payer system and you don't have accountability, then you've got a problem. If you have a two-payer system and you have accountability, you have things under control. So the appetite to go from a very schizophrenic portfolio of insurance companies that we have now to a universal single payer is going to take an incredible amount of politicking, political will, and capital. I do not know that we can do that. If we can, it is a preferred scenario. But the alternative of the dual is not that bad, in my opinion. That's just my opinion. The other issue about physician salaries, I think it is, well, it may not be well known that the salary profiles of American physicians is the highest in the world. It's not a bad thing to be highly trained and to earn large revenues, but part of the waste is actually driven by physician behavior that is not held accountable to best practice. Depending on where one lives and practices, there may not be the appropriate peer review, supervision, and collaboration, as well as hospital system structures and policies to hold people accountable. And we as physicians know this, that there are several places where doctors are thrown in jail for doing the most dastardly things. Operating on people that don't need surgery. Doing procedures on people for no reason, for no clinical reason. When you hold doctors accountable for that, then salaries will come down because they are no longer able to run amok within society. So that's number one. Number two, somebody spoke about hospitals going out of business. In the United States, part of the waste is the fact that there are too many hospitals in certain areas, and some hospitals actually need to close. There are too many hospitals, there are too many diagnostic centers, and duplication of capabilities and assets. Within 1 mile between hospitals, you have the same things. I think I read a statistic many years ago that Charlotte, North Carolina had more MRI scans about 30 years ago than Canada. Now, we had about 6. I don't know if it was true, but the point is that what we call asset rationalization in healthcare industry is very, very indisciplined. And when you remove that, then salaries go down not just for physicians, they go now for executives, but they become more calibrated to reality. And when you have the opportunity to have the right numbers of facilities, then the volumes actually now come to designated areas. And with increased volumes, those that are actually performing appropriately may actually see a maintenance of their salaries, or may even go up. But some people will go out of business. Some doctors will go out of business. Some specialties. And you know, myself, as a cardiologist, and my orthopedist friend there, knows that we are highly scrutinized as proceduralists. And within our world, I would openly say that there's a lot of bad behavior that goes on.
So,
More good than bad, but a lot of bad.
Last question?
can I,
Oh, sure.
a couple of things. First of all, I'd like to, with regard to the salaries, I think that, realistically what would happen is that net salaries for primary care physicians would probably go up. There would probably be some decrease for some highly paid subspecialists, which might affect some people in this room. But one thing to remember is that part of what goes into physician compensation and gross salaries is a lot of administrative costs that would decrease because physician offices would only be dealing with one payer instead of 100 payers. They'd only have one set of rules and forms and so on, and that would decrease the overhead for offices. But I also wanted to answer your first question because I don't think anybody addressed that about the different plans that various candidates and various people in Congress have. So there's a bill in the House and a bill in the Senate that are both called the Medicare for All Act of 2019, and those are true improved Medicare for all bills. 10 years ago, you can talk about Medicare for all. It was very unpopular and nobody would have conversations about it. Now, the phrase has become so popular that everybody has some version of Medicare for all, except I would say to all of you, beware. Because there are all these bills in Congress, and they're called the Medicare for More bills, but a group of them. But there's like Medicare for America, and they have different names. What they basically are is they're all variations of some kind of public option or some kind of ability for people who want it to buy into Medicare. And that's what you'll hear a lot of the candidates have been talking this up, like we're going to give Medicare to more people, and people can have the option, they can have it or not. But I want to caution you about these bills. They're what's called incremental change, they're gradual. And that sounds appealing to people because it's not as big a change, so it seems like we'll get somewhere better. But they have at least three big shortcomings. The first is that they're options. And so what that means is that we will not achieve universal health care with them. And the problem with that is it seems like, well, why should anybody who walks out get health care? But some people still won't be able to afford health care, and that's why they'll opt out, or they won't understand what their options are, and they'll opt out. And some people will just say, I'm 20 years old and I'm healthy, what do I need? I don't need health insurance, I didn't need it last year. But those people won't then get health care that they need, and that's not good for us as a society. But the other part for us is, so then when they have their motorcycle accident, they may still need health care even though they didn't get health insurance. And then we all pay, and we pay in the most inefficient way. So that's one problem. The second problem is that one of the big public reasons to go to a real Medicare for all, which is a single payer system, and get rid of private insurance companies and have one payer, not one provider of care. We'll still have private practices, but we only have one entity that pays the bills, is that all those over $1 trillion of inefficiencies that Dr. Lugo was talking about, a lot of that has to do with the fact that we're paying all these different insurance companies and you get huge administrative savings. Well, if you just create a system with a public option or people providing Medicare, or you're just adding one more layer to an already complex system, and you don't get the savings. And then the third reason is that if you let people opt in, who's going to opt into a government system? People who really need health care. People who feel like they're well are going to keep, they may have lower premiums on their, they may have some low premium, high deductible plan with their insurer or somewhere else, and you'll get the sick people in the public system, which will make it more expensive. And then other people will look at it and they'll say, well, see, the government can't do anything. The people they're taking care of are expensive. And insurance companies will get to skim people. And basically what they'll be doing is insuring well people, which is what they want to do anyway, and not have medical expenses. So the point that I want to make to you is look out for these plans. The things that sound like they're a gradual way and a somewhat seductive way to get there aren't necessarily better.
Okay, we're up against the clock. Presley?
No, I